Hi, I'm Dr. Jeff Janis, Professor of Plastic Surgery at Ohio State University Wexner Medical Center. And first and foremost, let me appreciate you for choosing me as your surgeon. I want to explain what's going to happen with your upcoming abdominal wall reconstruction surgery so that you are fully prepared. First of all, the nurses will call you before surgery to let you know where and when to show up, what to wear, what not to wear, when to stop eating, and even directions on how to get there. Then the morning of surgery, you'll see one of your two surgeons. Of course, we have our general surgeon and the plastic surgeon, the hole digger and the hole filler. And you'll see one of us the morning of surgery in order to answer any last-minute questions that you have between now and the date of surgery. So if you do have questions, please write them down, and we'll make sure that we get to those before you go back to the operating room. Then, before any further questions, we'll get you an IV and we'll get you some I don't care medicine after all of your questions are answered. We'll get you back to the operating room where you'll be scooted over to a warmed operating room table. The anesthesiologist will give you an oxygen mask to breathe, and you'll count backwards from 10 to 1. You'll make it to about 8, and then you'll blink your eyes, and next thing you know, you wake up in the recovery room. And your surgery, at least as you perceive it, will be over. From there, you're going to end up being admitted to the hospital. Now, the vast majority of our patients go to the floor rather than to the intensive care unit. The intensive care unit would be a special situation that I would explain to you before surgery myself. But usually what happens is you'll go to the floor where you're going to be taken care of by a team of people who are very used to taking care of hernia patients after surgery. We have absolute dedication to making sure that we get you safely from the front door, back out the front door, and to home to recover after surgery. So what to expect? Let's get into some details. First of all, your surgery is going to likely take several hours. I would plan on an all-day operation. And I know that sounds scary, but if you have a complicated abdominal wall reconstruction or a complicated hernia, I can assure you that nobody is rushing. There's not going to be a case before you or after you. We take our time to do it right. Your general surgeon will go first. They'll start with the incision, they'll put things back where they belong, and clean up any scar tissue. They'll take out any old mesh, if that's what you have, in order to get back to scratch, and take out anything that you don't need. Then I'll come in and essentially build the abdominal wall from the inside out. The way that I do that, and the way that I would like to explain it to you, is like a sweater and a winter jacket. First, we'll put on the sweater. The sweater is a piece of mesh. And in some cases, that's made out of a sterile plastic, and in some cases, it's made out of basically sterile pigskin called biologic. I'll discuss with you in your clinic visit which mesh is the one that's appropriate for you and why. But the mesh goes underneath your muscles. So think of it like putting a sweater on before you put on your winter jacket. The winter jacket are your muscles. And oftentimes, when I'm involved in your surgery, that means it's complex. That's why a plastic surgeon is involved in your care. So I'll be moving muscles around, kind of like two sides of the winter jacket. I'm going to move the muscles around to get the muscles back together in the middle, which is how they started out before you had your hernia. Your muscles in particular are called your rectus muscles. These are your sit-up muscles or your crunch muscles. These are the muscles that look like a number 11 because they're right next to each other, one on your left and one on your right. And right now, they look more like a V because there's a hole in between them. That hole is your hernia. So what I do is I put the mesh underneath your muscles, I get the two muscles together in the middle, and I zip them up like zipping up two sides of a winter jacket. Now, in most people, we're able to get the zipper up all the way to the top. In some people, we're only able to get the zipper up about halfway or so. And in rare situations, there may be a situation where it's like the winter jacket is too small or the person is too big and you just can't get the two sides of the winter jacket together. You can't even get the little zipper engaged, let alone zipped all the way up. Think of it like a vest and a sweater underneath. So at the very least in that situation, you have the mesh. But in the best situation, it's nice and warm because you have a sweater and a winter jacket zipped all the way up to the top. That is a complex hernia repair, and that's what I do when I'm involved in your care. Now afterwards you will have drains, which are soft plastic tubes connected to what looks like little hand grenades. And the purpose of those drains is to take fluid away from your body so that it doesn't collect and cause a problem. You will definitely have at least one drain and oftentimes more. and you will definitely leave the hospital with those drains. It would be quite rare for you to get even one of those drains out before you go. Now, we will provide separate information to you about how to care for those drains during your preoperative clinic visit. We will also reinforce that education to you while you're in the hospital, and I will give you a piece of paper, either myself or my nurses, that has instructions, not just in writing, but also pictures, so that you can see how to take care of your drains, which is very straightforward. The other thing that we focus on is pain control. We want you to be as comfortable as possible after this operation. At first, that involves some IV medications, but as soon as we can, we will transition you to pill form medications, which are the type of medications that you can go home with, because you're not going to be going home with an IV. So we use multiple different kinds of medications in order to make you as comfortable as possible. All but one of those is not a narcotic. We use something called multimodal analgesia. What that means is multiple different kinds of medications in order to control your pain. Most of these we have you take around the clock. For instance, Tylenol is one of the medications. Simple over-the-counter Tylenol that you take every 6 hours around the clock will help stay in front of your pain rather than respond to your pain. We have other medications as well that we will go through in detail with you to make sure that you understand how and when to take them. We also provide a narcotic, which is the backup plan. The backup plan is often used only for the first few days or maybe the first week or two after surgery. The first day after surgery is the worst day, and I'm just being honest with you. The first day of surgery, you're still a little groggy from the anesthesia, and I've given you a long-acting numbing medicine which actually lasts for 3 days, which helps make you more comfortable while you're in the hospital. But the next day after surgery, when anesthesia has worn off and you're more awake and aware of what's going on, that's when you understand that you've had an operation that requires some pain medication. So again, we'll explain all of this to you, but I wanted to give you a preview that that is normal after surgery. Now, your recovery period will be approximately 6 weeks, and during that 6 weeks, you will have some do's and don'ts. Let's start with the do side. We do want you to eat a high-protein, low-salt diet. Now, at first, you won't be eating anything after surgery because it is normal and natural after surgery for your gut to shut down. You don't get the cheeseburger and fries or the meatloaf right after surgery. That will stay like a brick in your stomach and make you feel bloated, nauseated, or even vomit, which, as you can imagine, we definitely don't want you to do after repairing your abdominal wall. But when your general surgeon allows you to eat, at first you'll be taking sips of what's called clear liquids. These are things like juice, jello, tea, broth, Sprite, real easy to digest things. Then you'll move on to more substantial foods. And by the time you leave the hospital, you'll be eating regular food. We would like you to emphasize protein. It doesn't matter what kind of protein that is, whether it's beef, chicken, fish, vegetable protein, shakes, bars, powders, cookies, whatever it is that's high protein, low salt, more of what you need, less of what you don't. Protein is the gas that fills the gas tank. And let me assure you, after surgery, your gas tank is going to be depleted because you are revving that engine in order to heal after surgery. So high protein, low salt diet. We also want you to take deep breaths. We'll give you what looks to be a plastic lung exerciser after surgery that will be very important to prevent fever and pneumonia. And of course, we don't reuse those, so you'll be going home from the hospital with that as well. The third thing is walking. I hate to say it, and it's a little bit of bad cop, but we will be getting you up and walking even the day of surgery. Now, we don't expect you to do that on your own. We have plenty of assistants on the floor in order to help get you out of bed and walk you even just a few feet. And I'm not talking about laps around the hospital or the medical center or even laps up and down the hallway. For the first day, I don't even mind if you get up, touch the door of your room, and sit back down. That counts. The first day after surgery, at least once or twice. But then, after that, 5 times a day. 5 times a day in order to prevent blood clots, which can develop in your legs and could potentially break off and go to your lungs, which is a very serious problem. That's why we also have leg squeezers on your legs during the operation. It tricks your body into thinking that you're walking around the block when clearly you're not. But what it does is help prevent complications. The last thing on the do list is wear your abdominal binder, which is like a stretchy Velcro corset. And that's designed to help make you more comfortable and support you during the healing process. So to summarize, the do's for 6 weeks after surgery: eat, breathe, walk, and wear your binder. When you take your binder off to wash it or dry it, or even if to get in the shower, you don't have to hold your abdomen. Nothing's going to come out, nothing's going to pop or tear. So it's okay to relax for the couple of hours or whatever time it takes for you to do that. The don'ts for 6 weeks: no heavy lifting, nothing heavier than a gallon of milk. No strenuous activity, nothing that hurts, nothing that makes you sweat. Don't go into a bathtub or a pool or anything that submerges your incision or your abdomen underwater. However, a shower is okay, letting the water just drift over your incision. Pat dry and don't rub. We don't want you to do any movements which can place tension on the incision. That includes torquing your incision from side to side, or even reaching up to grab something, let's say a glass out of a cabinet or off of a shelf, or even bending over to tie your shoes. Anything that puts tension on the incision needs to be avoided for 6 weeks. By following these directions, we essentially allow the cement to dry before you walk on it. And that will be important to delivering the long-lasting outcomes that we're looking for. Now, ultimately, I must say that I'm very conservative, and I won't even start to think about being a little bit more comfortable until we are at least 3 years out from your operation. And I know that may seem astonishing or surprising, but the reason is because most hernias come back within 3 years after surgery. Not all of them, but many of them. That's obviously not the goal of the operation. So I want to see you at first quite often after surgery to make sure that we get you from point A to point B and you get to be recovered. But when we get to a certain point, I will see you about once a year on the anniversary of your date of surgery. And I will see you every year thereafter, so that if there is something even small going on that potentially I can detect, I'd like to pick that up while it's still small before it gets to be a big problem. So again, I will finish how I started. I sincerely appreciate the fact that you have provided me the honor of serving you as your surgeon in your upcoming surgery. I hope that some of this information helps dispel some of the anxiety around surgery, although I know surgery still causes anxiety. I want to provide you with as much transparent information as possible so that you can be well educated as you walk into your hernia repair. If you have any additional questions, please write them down, and both myself and my nurses will be more than happy to answer those during our visits before, during, and after surgery. Thank you again for choosing me as your surgeon.